Hi, my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to Five Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crowe.
I'm Jesse Spur, and this is a podcast by, for, and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to Five Things.
Hello, my name is Liz Crowe.
I'm Jesse Spur.
Welcome to another episode of Five Things. And today we're doing something that people have been begging us to do for a long time. We are welcoming Lita Jeffries, who's the clinical lead for the Queensland Occupational Violence Strategy Unit. And she has come in to talk to us all things OVP or occupational violence. How are you?
I'm great, thank you. Thanks for having me.
Now, how the heck did you get here? This is going to be a doozy of an origin story.
It really is. Look, firstly, I think it's an absolute privilege to be able to represent and support nurses from a strategic perspective. I've certainly had my own experiences. I'm an emergency nurse by trade. I think you can take the girl out of ED, but there's always a bit of ED still in the nurse. And look, I had my own experience. I was pregnant and I was assaulted by an intoxicated patient. I have been at triage on more than one occasion where someone has told me they've had a bomb strapped to their chest. And one of the highest level incidents that I was involved in actually resulted in some really significant harm to some colleagues. And that really put me on this trajectory. And I was told on more than one occasion by nursing leadership that occupational violence is not a nursing responsibility and it's not a career path. But 8 years later, here I am.
Yeah, hooray for you. So let's just get straight into this. This is like becoming such a significant concern and problems right across health. Can you start by telling us what is occupational violence?
Yeah, and I guess the biggest thing to acknowledge is that it's complex. Yeah. Queensland Health has an endorsed definition of occupational violence, and that is that it's any incident where an employee is abused, harassed, threatened or assaulted by a patient, consumer, their relatives or a member of the public in circumstances arising out of their employment, irrespective of the intent for harm. And for me, that's the key. It's not about whether they intended to harm. It's about the fact that you were caused harm.
Yeah, right. And so I guess with that broad definition, it's anything really where the staff member feels harmed by the interaction as determined by them, isn't it?
Oh, absolutely. And that varies. And I think that's the biggest point as well. Just because I've had 15 years in an emergency department, my level of exposure and my tolerance is going to be really different to someone who's not had that experience or exposure. It doesn't make mine any better or greater or theirs any less.
Yeah. And I think there's a problem, isn't there, right across the board for all healthcare professionals, but I think nursing in the front line of what you've put up with for years. And so it's kind of normalised. And now we've got, rightly so, a number of people saying this is not okay. So as a social worker, I've been sworn at so many times that, someone's swearing at me like, I don't know, I just don't sort of pay any attention to it. But that doesn't mean that it's okay. That's a desensitization to it, isn't it?
Absolutely. And again, it comes to that exposure. I've had many, many resusces and traumas where I've been involved in. And, the high level stuff is, I guess it's that desensitization. Again, I'm not suggesting that somebody else who experiences their very first cardiac arrest on a ward is any less to them because I've seen more of it. It's so relative to the person, to their experience,
to their history, their context.
Absolutely. And we've all got a past. And I think the hardest thing in healthcare is to remember the vast majority of occupational violence incidents that do occur are actually from people who don't have capacity. And that is why there's such a big desensitization, and we do tend to tolerate it, and we accept that people are fearful and scared and, this is unusual. And so that that pendulum swung so far now that everyone's kind of gone, oh crap, we probably need to do something about it.
Yeah. I was working with a nurse this week who has had a terrible incident of OVP. And she made a really good point to me where she was saying, like, everyone kept talking about the patient's trauma background.
Yeah.
And of course, we have to be compassionate and mindful. And she's like, but people don't know what my trauma background is. And, that's so true, isn't it?
Oh, you just gave me goosebumps, 100%. And I think at the core of every incident is someone with a history, but that doesn't necessarily mean the patient. And our tolerance level is that cumulative factor as well. If you've just had the crappiest morning where the kids can't find their shoes, but 2 seconds ago they were on their feet and you're running late and, you just know the sort of day, and then someone comes and just hammers you and you're like, I'm done. Like I'm at
my threshold.
Yeah. And your cup is empty and you have to keep finding that bit to give. But at some point it's, enough is enough.
So number 2, you've already alluded to the fact that this is a complex subject. So your number 2 is about how do we actually understand occupational violence and prevention?
I guess for me, I tell everybody, pretty much anybody who'll listen, I do believe that it is the most unique scenario that violent in healthcare, because as I mentioned before, the vast majority of people don't have capacity, and that doesn't mean that we need to excuse it or accept it, but it does have to have that other layer of complexity, I guess, to be able to manage. I think it's a challenge when we have so many different intersecting pieces of legislation. That means that, every person's managed a little bit differently. We have to impose boundaries in some situations. We're enforcing smoking when we know that's something that will actually calm someone down, and that's such a fine balance. But I think for me, COVID really highlighted that people tend to come to hospital for 4 reasons, and it's their first day, their last day, their best day, or their worst day, or some sort of variant of that. And, you can just stop in the middle of a big facility like this and see so many people looking at signs and looking around, and there's fear and there's stress and there's so many underlying factors that are just from the patient perspective. So I guess for me, when we're understanding, it's about looking at the big picture. There isn't a silver bullet to fix it. Society has increased in their level of violence and the exposure. And I think it's probably a bit ignorant to think that that's not going to then transpire into the healthcare setting.
It is tricky because we're talking about a social phenomenon, as you said also, that is impacted by quite confusing variability in legislation that piles acts on top of each other, and that kind of sense of duty that we have every day we come to work as well can just get really blurry. And then there can also be the individual variance or the cultural tolerance in a particular workspace, like you alluded to in ED. So it's multifactorial of kind of building those layers down and getting an understanding of each. But also I think looking at each individual circumstance in terms of a risk profile, and also talking about sort of hypotheticals and scenarios in which in your workplace might be the types of things you might get exposed to. One of the challenges I've seen is with the shifting in like generational values. And my daughter's 22, starting her nursing career now in ICU. She has the whole spectrum of language from pathological mental health psychology to apply to just general well-being. So her sense of kind of what's tolerable or what shouldn't be tolerated is very firm, when sometimes a lot of us who have been around a bit longer and don't necessarily pathologize our own emotions as much will have some really hard boundaries, but then there's a whole variance of what are those softer boundaries.
I think that you've absolutely hit the nail on the head. Also, she's following in Dad's footsteps. How cool. I think for me, it's I think we need to, as a workforce, need to acknowledge that our own values and our own moral compass plays a huge part in this.
So your number 3 is about talking to us about risk factors for OVP. Like there's a lot of science out there. Like what do we know? Where are the pressure points?
I think you could look anywhere around any hospital or any facility and see that there are a number of pressure points. the big ones are fear and anxiety, pain. We have these highly stimulated environments, and we often put our, most vulnerable and sickest people. I think back to times where I've had to work in ICU, and even though someone's intubated, they're not well rested. There's noise. There's, so there's so many complicating environmental factors. I think it's community expectation as well, and you just have to turn on any sort of media outlet to see that, there's likely going to be something health related. And I don't necessarily think that the expectations of community are even achievable at times. We've got lengthy wait times in EDs. We've got ambulance ramping. We've got staff that are tired and compassion fatigued. And I do think that's a real issue, and that does impact on the delivery of patient care.
Is there a time of the day or is there a day of the week when we look at the data that we know that OV is greater than any other time of day?
I think if you ask society, the general perception will be any sort of weekend night in an emergency department, it's going to be chaos. I think you could go any night of the week these days and see that the place is still buzzing. There's no downtime anymore. There's no reset. The peaks and troughs kind of really still sit varied. And I do think that it really does depend on your environment and your patient demographics as well. So we won't consistently across the state see the same trends, which, is indicative of that social demographic as well.
Okay.
And there's ones that don't readily jump to mind but seem really logical in retrospect. So like maternity and birth suite areas actually have really high risk because while for some people it's a best day, first day, for a lot it's not. There's often domestic and family violence that spills into those settings. There's alienated partners. There's all sorts of things.
Yeah, so that's where we see the best and first, but we can also see the worst and last. That trauma or having someone come in and having the death of a loved one, whether that be at any age, can be really traumatic and triggering for people. And people do naturally think that violence is mental health, drugs and alcohol emergency department. It's so much bigger than that. Our delirium, our patients who, have a vulnerable hospital-acquired delirium, or whether there's a complex comorbidity, or for me, I think it's wild that we don't see that our mental health patients or a patient with a mental illness will become physically unwell or vice versa. It's like we only treat that symptom or that disease process that they're in hospital for right now, but they're so much bigger than that presentation.
So is it a bit of a myth? Because I thought, particularly patients who are suffering from delirium or cognitive impairment, that kind of like the going down of the sun, often that is a triggering time, potentially threatening behaviours. Is that a myth?
Look, it's not a myth. It does absolutely still occur in that sort of late afternoon space, but that's not consistent across the whole of the healthcare setting either. So,
right.
You may have those older person areas, or, as we do see more and more outlying patients, maybe not in their home wards or in the ward that they would normally be in, to have that sort of specialised care, that are seeing it. So it may not be as concentrated.
It's a really good example, though, of where the complexity comes in with this as well, because our tolerance and workflows are designed towards a going quieter at those times of day as well, and a reducing of things. So the perception and the tolerance and that kind of boundaries that we're setting may be tighter than as we go into night, with less staffing in most settings outside of one-on-one care settings. So it can appear to be higher, but it can just be that behaviour is more discordant with what the expectation is at that time of the day as well.
And we also cohort these patients, who have that sort of vulnerability. And we put them right next to the nurses' station so that they can, have that visual observation. However, the lights are going, it's the middle of the night, there's that pinging, they're the most high risk, so the nurses are bustling up and down. And we've kind of missed the point that these people need to rest during that time to help their recovery so that they can get better.
Yeah. So it is so complex and multifactorial, as you've both already said. All right. So your number 4 is really about examining the impact on the workforce about occupational violence, and also talking about this whole thing around zero tolerance.
I hate it.
Yeah.
I hate the term. I really do. And I think for me, even just looking back on my own experiences, there are so many times in the healthcare setting that we do tolerate it. We do accept. And I think, there's an element of this ethical dilemma that I will often, talk to my colleagues and new grads and anyone who will really listen. But there is that ethical dilemma that we feel this desire, this need to go in and help, to go in and solve, because that's why we're nurses. We're in the healthcare profession for that reason. So we'll run in, and it's not always the best thing. When we talk zero tolerance, it's unachievable. And it becomes nothing more than just words. And I think if we're going to put something meaningful in place, we need to look at what those words do to the people who are at the receiving end of that. So, I could walk past any nurse, I think in any hospital, and ask them how they feel about zero tolerance. And the majority of them will say that it's rubbish because we do tolerate it. It is a policy statement. And I think that we can use words that are probably more appropriate in this and I guess resonate more with the staff at this point.
Yeah.
I think it speaks again to a lack of agency that nurses have in this stuff is like when these sorts of things make it to a policy statement, make it to signage on buses, make it to signs around a hospital campus, and not one nurse feels it.
Yeah.
It can be so indicative to part of a generalized problem that I see in occupational violence, is where nurses are largely thrown into situations a lot of the time, or I guess thrown in is probably not fair.
Yeah.
Delivering care under a plan that they've had very little agency in actually devising, and have very little tools in their tool belt given to them in those plans, of often plans that are made on a ward round or from an office. The same way that a zero tolerance poster design has been made very disconnected from them.
Absolutely. I look around and I think back onto some of the occasions where I've spoken to nurses who have been involved in some really rubbish situations and had exposure where they probably didn't need to have had that exposure, but either there's a lack of empowerment to set a clear boundary for someone who does have capacity under that zero tolerance kind of framework or wording, to then have it swing the other way, where you have a nurse who is so completely exhausted, who's just said, called the police on a 90-year-old dementia patient because they've lashed out. I understand the complexities behind all of that, and their feelings are absolutely valid, but we need to find that balance about where our patients have and don't have capacity. It's not diminishing the fact that they have been exposed to that, but what do we want as the outcome of that? And a lot of it comes from poor planning and engagement. It is absolutely a multidisciplinary team that needs to be involved. And I think one of the big key things that I think is missing from that multidisciplinary team a lot of the time is security officers. And they are the ones who are the risk experts. They're not there to talk about the clinical component, but they have that knowledge and skill about risk. And we don't always include them as much as we should.
So what are some of the impacts of occupational violence on the workforce?
I think we're seeing trends about longevity in the workforce. Obviously, retention is a huge issue in general. And then having a healthy workforce is probably the most difficult thing from a management perspective. I know that if we feel safe in the workplace, then we're going to deliver good care, but it's a real balance between putting in some meaningful solutions and not having tokenistic words or policy statements or EAP referrals, etc. We need to, I think if the staff are feeling underloved or more exposed to OV, we need to really encourage some of that conversation. And that's a challenge, as you know, in that senior management kind of perspective. But the have our say surveys, all of our I guess employment indicators are saying that people are feeling tired and burnt out, and compassion fatigued, and that violence is a risk. So I think having that conversation with them about putting in some of those strategies is going to be really important.
That leads us perfectly to our number 5, which is around prevention and management of occupational violence. What are the key tips? Like, I guess the thing I'm hearing is communication and relationships is everything, both with patients, with their family and friends, but also with each other, with our security officers, with people who are involved. But what are some other really tangible things that you think we could tweak, which hopefully might make some differences?
I think the first thing to acknowledge is that this is like a big puzzle. There's no one size fits all. And if we do things half-heartedly, then it just becomes a Band-Aid on an amputation. This situation, the management of occupational violence has to be a multidisciplinary approach. It absolutely has to have all the stakeholders. And there are elements of, I guess from our unit's perspective, we look at occupational violence and the management of it under 4 pillars. We look at awareness, prevention, during the incident and in the post-incident space. And there needs to be really robust support mechanisms and machinery under that to allow the implementation of some sustainable solutions under each of those pillars. From awareness, we need to openly talk to people about it. And that's about having these conversations. Well, in our unit, we see lots of patients that don't have capacity, but what can we do to identify these issues, or maybe have a conversation with families or other agencies or even other disciplines within the hospital to kind of draw on some of those strategies that already exist. It's just about connecting the dots.
You talked a little bit off air before we started about an interesting experience and hearing some thoughts from security officers in terms of what they'd like nurses to hear. I'd be really curious about that.
Just this last week, we've had the privilege of sitting with the security managers across the state and, their coordinators as well, as part of the Queensland Security Manager Network. And that's something that we formed many, many years ago because there wasn't any centralised governance of security across Queensland Health. And for us, it's such a good opportunity to get their insight, but really have that conversation about balancing, patients versus prisoners, how we really manage the complexities and have that understanding. Are we giving them enough tools to know that clinical environment as opposed to just the risk environment? But I did have an opportunity yesterday during one of the sessions to let them know about what we were doing. And I wanted to ask their opinion because, again, I've been in so many situations where I've needed to call security and they have saved my bum on more than one occasions. And they've gone, wow, Lee, that could have gone really bad. And yep. So for me, I do respect their input, and culture does play a big part in that, how we build that relationship. But we need to absolutely have those conversations with them, engage them early. And these were really the themes that popped out. I asked them what they thought, if they could tell nurses one thing, what would it be? And it was very easy to group that. The first thing they really wanted to say was that they're here to help. Call them early. They would much rather be able to engage with a patient or the family or in a situation early. I think we do them a bit of a disservice sometimes when everything's kind of hit the fan and then we call them thinking that they're going to come in and solve a situation. It ends up really messy and needing to go hands-on when ideally going hands-on should be the very, very last thing we do. So calling them early, I think, to give them an opportunity to engage and have an opportunity to do that verbal de-escalation. Give them a handover. This is one of my pet hates. I have spoken to loads of nurses across the state and also interstate around why would we give them a handover? They're like security. They are, but that's their PPE. Like any of this should be our PPE. They are bound by the same code of conduct and confidentiality as we all are, but for us to not provide them with adequate information about the person, about their voluntary or involuntary status. Like that essentially is the difference between a lawful detainment, maybe under the Mental Health or Public Health Act, versus an unlawful detainment and therefore an assault. So there's some really huge legislative risks that could occur if we don't give an appropriate handover. Being aware that security officers don't have infinite legislative powers under the Hospital and Health Boards Act in Queensland, their powers are really limited. They do a brilliant job for the powers that they do have, but again, they're limited. So I think while we need to acknowledge the role of security, it's just as important to understand the, I guess, limitations. Yeah, thank you, of them. Environmental, that was huge. I always giggle because for as long as I've done my basic life support or advanced life support, it's always been about danger. Okay, is the defib in a pool of water? I don't know when a defib is ever going to be in a pool of water, but we don't, like, it's wild.
I have done a resus in the hydrotherapy pool here at Royal Brisbane, not in it, dragged a patient that had been dragged out. So, well,
there's a first. So in my nearly 20 years, that's the first I've actually heard. But every time I do my refresher or have done, everyone's like, okay, the defib's cool. There's no water around. I'm like, why are we not looking at the angry person in the corner or the stressed out mother? There are so many environmental factors that we don't look at. Oxygen tubing that could be used. One of the guys yesterday said a tendon hammer. Didn't even think about that one, but how sharp is the end of a tendon hammer?
Yeah.
That obviously could be used as a weapon. Communication is everything. It really is. And they really wanted nurses to know that it's okay to tap out. It's okay to know that it's maybe a futile conversation and they need to tap out. And by tapping out actually allows someone to decompress themselves, or it also allows us to make a plan. And a planned response will always be more effective and safer for everybody than a reactive response.
I often say to people that, if someone's got a cognitive impairment or if someone is absolutely intoxicated or if they're furious, it's all the same thing. Like there's no rationalizing.
Yep.
So stop, just get out of the way. There's no amount of like, come on now, like we need to get you back. Like you've passed that point.
Yep.
We're trying to apply very rational thinking plans to people who are not in that same headspace.
Absolutely. And I think that is where they're coming from. It's allowing them the opportunity to decompress, or allowing them, if they're safe, then it's okay for us to let that situation be. If there's no risk to another patient or to another staff member, coming back in a few minutes.
Yeah. If someone's saying, get away from me, don't, not walk it. Not that it's the healthcare professional's fault, but I'm just saying sometimes we're getting cues off people that we're not paying attention to.
Absolutely. And we don't see risk. I think as clinicians, we're very task focused. We have become, very regimented in our structure, in our care delivery. We've got tasks that we need to make sure that our patients, get the medication, get the next thing, do the blood test, do the blood pressure. But having a meaningful engagement with someone and finding out a little bit about them can actually be the biggest key to keeping the situation calm. So I've heard many, many situations. In fact, one really beautiful story that I heard was about an older lady who just kept spitting on anyone who went near her. And it took someone to actually sit down and say, what did mum do? We're having some challenges in trying to really keep everybody safe here. Well, it turned out that mum was a lollipop lady for many, many, many years, and she wasn't spitting, she was blowing her whistle. So
yeah,
the next day someone walked in with a whistle without the P in it,
yeah,
and gave it to her, and she was so calm.
Yeah.
There are so many stories like that, and everybody comes with a story. And again, there's no excuse for some of these underlying situations or the reactive and potentially intentional situations, but sometimes we just do need to slow it down and unpack the situation a little bit more, because I'm sure there's many people out there that have a lollipop lady story, you know?
Yep.
We talk about training. Everyone's like, oh, well, you've had a really bad incident. You need to go to training. Well, it kind of is a bit of a slap in the face nearly because, you're basically saying that I am not skilled enough maybe, and that's what led to that incident occurring, when in fact training should be just one of the big pieces of the puzzle. It won't be everything, but working on those scenarios that you most commonly face is really important to have that conversation and networking between your trainers. Most health services across Queensland have dedicated occupational violence prevention trainers, and it's about drawing on that skill and knowledge and putting those strategies into play. I guess under prevention, again, it's identifying any of those either triggers or previous, whether it be alerts or presentations where, we're aware of someone's history, whether that be violent or not. The biggest indicator of a violent incident will be a history of a violent incident. But that also means that we don't necessarily have to avoid that person, because that actually will make people more angry. I think having conversations with patients and setting those boundaries, and that is something that is so difficult, and I completely acknowledge that. That takes a lot of skill to say, actually, I don't appreciate when you do that, and we can't continue to safely treat you if this is the way that you're behaving. And that comes with experience, but also, it's a bit of a double-edged sword, because that means that people have then been exposed to violent incidents or potentially violent incidents. I think in the post-incident space, the only thing I would say is using evidence-based frameworks. We developed the incident response kits as something to just really step out some of those key factors and acknowledging that everybody's situation is different and how they're going to handle it. I remember one time seeing an incident and not being able to call 000 because I couldn't press 0 to dial out. I'd been nursing for 15 years at that point in emergency, and I don't know what happened in that situation, but it's that fight, flight, freeze sort of response. And it's acknowledging that, not beating myself up for the fact that I couldn't call 000, but acknowledging that there are other factors that probably came into play there that we needed to look at prior to it getting to that point. For us to provide great post-incident support, we know that people will come back to the workforce and be well in the workforce if they are provided adequate post-incident response. However, if there's no formal incident report or escalation, it makes it very difficult to provide staff with that adequate support. And, as nurses, we always say if it's not documented, it didn't happen. Just last week, I was actually had a very robust conversation, or I was on the other end of a robust conversation with someone saying that it was just absolutely political. Like we shouldn't have to fill out these lengthy forms and have these, have this imposition of filling it out when it happens so often and it takes up all our time. But on reflection, when asking them about what their numbers, like their actual recorded numbers of occupational violence were in their area, they were really low. And I was like, well, I don't know how we can influence change or escalate to change if the numbers are so low. So I think without saying, every incident is going to be just as important as the last, but if it isn't reported, it didn't happen, and we can't make change based on, anecdotal feedback. We need the evidence to be able to influence.
And what's the best way to report an incident, particularly within Queensland Health?
So across Queensland, the incident reporting system would be Riskman. We find that depending on the patient's clinical condition will depend on whether that gets reported as a patient incident or a worker incident. Regardless, obviously it would be great if you did it in both, but we know that has its own challenges. Ideally, as long as it's reported, to be able to say that these are the incidents that are occurring, formally report it via Riskman. Security will do their own sort of incident reporting if they are involved in situations as well. And it's obviously putting alerts on for other staff to then enable that as their own PPE.
And document the exact language, use quotes.
Absolutely.
This is something I find really funny because it feels really
naughty,
vulnerable to write a swear word in the notes. But document the exact language that's been used in the clinical notes as well, if it's a relevant clinical interaction, and certainly in the incident report. I've had a few people shifts after I've documented something that have gone, wow, I read your note about that. I could feel like I was there. And it's like, that's what we've got to produce change, to actually relay the impact of it.
Absolutely.
Okay, Lita, that's been so helpful. And I'm going to try and really just summarize very briefly all of that wonderful information. The number one is, what is occupational violence? And we know it's verbal, physical, psychological, sexual, it's threats. But the things that are take home for me is that it's extremely complex, and that it's any incident of abuse, harassment, threats, or assaults, and it's irrespective of intent to harm. So that means that, yes, people who are cognitively impaired can still inflict occupational violence against you, even though they had no intent to harm. Number two is understanding that occupational violence is actually really multifactorial. It's complicated. It has issues around capacity and ethics. And you mentioned that, in health, we're in this very unique scenario where the vast amount of our perpetrators have no capacity, which makes it all very complicated. And I often say to people, if you worked in a hardware store, or if you were selling clothes today and someone treated you like that, that would be a police incident. But it's not that easy. And to have a look at the big picture and see that there are some societal and social phenomenons around that, and how often, for nurses in particular, this is very embedded in values, people's moral compass and sense of duty. Number three is, what are the risk factors? And you mentioned fear, anxiety, pain, stimulated environments, complicated environmental factors, community expectations, overcrowding, long waits, inflexibility around the system. But saying that, while everyone thinks of the emergency department, areas like maternity and birth suite also experience huge amounts of occupational violence, as do many of the other wards. Your number four was around zero tolerance and your frustrations with that and the impact on workforce. And so you were saying that it's a frustrating term because in actual fact we're over tolerant on many occasions. And you and Jessie had a lovely conversation, an important conversation really, around nurses' lack of agency at the bedside, and that often you're doing things that have been asked or requested where people may not understand the consequences of that. So you were just saying that be really proactive and engage security earlier, the better, and that that's their big take-home message as well. And that really, if we want to retain our staff and make sure that they're productive and healthy, then we need to really minimise all areas of occupational violence wherever possible. And number five was prevention and management of occupational violence. And you were saying, the biggest risk factors for violence is a history of violence, and that there's no one size fits all, but it's all about this shared responsibility, collaboration amongst the multidisciplinary team, and also sometimes patients and their families and friends, that communication is absolutely everything. Identify triggers and concerns early and act early. Don't tolerate. I often see that happen in the ward. There's this tolerate, and then everybody's just reached the point of no return. And I think you finished off with an important note about it's so vital to document, because if we don't have documentation, then we don't have the evidence. And then when we know someone has been involved in occupational violence, that we have to be really mindful and intentionally provide lots of post-incident support to make sure when those people come back to the workforce, we're looking after them so that we retain them. Lita, such an important conversation. Thank you so much today for joining us on 5 Things.
Thanks for having me.
The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2. And for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things